Hi, Derek.
Hi, sorry, who am I speaking to?
Sorry, you're speaking to Nicola from that essay. How are you?
Oh, well, thanks, and you, Nicola. Very well, thank you.
Well, thanks.
Um, I've got my presentation ready, um, and I just want to see. Oh, I see there's a share button at the bottom. So when the time comes, I will just share my presentation. Is that okay?
Yeah, do you want to test it now just to be safe?
Absolutely. Let me do that. Share this document, and I'll just put it in presentation mode. Um, how does that look? Is it okay?
Yes, that looks perfect.
Okay. All
And it's
right.
great.
Yeah, is that okay? So I'm just going to stop sharing and maybe just wait until 4 and then I'll continue. Is that okay?
So,
Or
Uta
do you want?
will introduce you and just do some housekeeping notes at 4, and then it's over to you.
Okay. Shall I? Well, maybe I mustn't keep this screen on. Yeah, I think I'll just wait for for Dr. Uta, and then I will share if that's okay.
Yeah, that's perfect.
All right. I'll mute until then. Thank you, Nicola.
All good.
Thank you.
Hi, Ute.
Hi, Nicole. It's Ute here. I've just asked in the chat, how do I get started? Can we get going?
Yeah, so normally, do you have the introductory slides? Otherwise, I can share them.
Yes, please. No, I don't have anything. Um, but I can introduce Derek.
Yes, so normally the chair will just speak through the introductory slides, but I'll share them now and give you control to advance them.
Okay. Where do I advance them?
I'm going to share, and then you'll just click on your screen as though it's coming from your computer.
Okay, okay, great.
Sure.
Okay, good afternoon, everybody. It's Ute Jens here from Sandbus, Johannesburg. I hope you're all well, and I want to thank you in advance. I see we have 95 people who've already joined us from, mainly probably the Cape and from Gauteng, but everybody else, welcome. So today our topic will focus on HLA, which stands for human leukocyte antigen. We will give you an overview, and the person who will be doing the overview is Mr. Derek Nelson. He is a medical technologist in the tissue immunology laboratory here in Johannesburg at Sandbus. He has spent most of his life, approximately 30 years, in this field, in laboratory diagnostics. He's seen the evolution of these technologies over time. And I think this is always a topic where it's good to do a revision if you're already knowledgeable in this field, or otherwise, for those of you who are becoming just familiar with this topic, this will give you a good overview, both in terms of HLA typing and also in terms of HLA antibody diagnostics. Please keep your questions for us either in the chat or after the talk. I hope you enjoy the talk. And with that, I will hand over to Derek. Derek, welcome, and thank you for giving this talk to this audience today.
Thank you, Dr. Uta, much appreciated. I just quickly want to share my presentation. Just let me know if you can see my presentation, Dr. Uta, and if you can just hear me.
Yes, I can hear you well. I can see your presentation well.
Okay.
And I just want to ask Nicole, is this in the presentation mode?
Yes, I can see it nicely on my side as well.
Great. Okay.
All
Okay,
right.
Derek, over to you.
Thanks, Dr. Uta. Good afternoon, everybody. So this is an overview of the HLA system, which can be quite a tricky topic. So I'll just go through all the slides and just give you all of the information. Just see why. Oh, there we go. So the HLA genes are found in the major histocompatibility complex, and they code for proteins that differentiate between self and non-self. That's quite important. They play a significant role in disease and immune defense. The primary biological role of HLA molecules is in the regulation of immune response. As you can see on this diagram at the bottom, the major histocompatibility complex is found on the short arm of chromosome 6. And HLA class 1 has genes for the A, B, and C locus. And the HLA class 2 genes are for DRB1, DRB3, DRB4, DRB5, DQ alpha, DQ beta, and DP alpha and DP beta. So HLA class 1 markers are expressed on all nucleated cells, and HLA class 2 markers are expressed on antigen presenting cells. So you might ask the question, what is an HLA typing? So it is the testing results of the identification of certain proteins in your blood called either antigens or alleles, depending on the resolution of typing that's performed. And at the bottom here, I've got an example of a report that we normally will send out, but I will speak to it in the next couple of slides. So it's important to know that half of an individual's HLA genes, or a haplotype, are inherited from your mother and half from your father. This means that siblings who have the same parents have a 25% chance of being HLA identical. They have a 50% chance of being HLA haploidentical, meaning they will share one haplotype, and a 25% chance that they will share no haplotypes. So HLA haplotypes are found more frequently in some population groups than expected by chance. This phenomenon is called linkage disequilibrium. An example of this is the A1B8 DR17 haplotype, being the most common in the Caucasian population. So this slide just explains how the haplotypes are inherited. So on the left-hand side here, we've got a father with 2 haplotypes and a mother with 2 haplotypes. So child 1 has inherited haplotype 2 from the mother and haplotype 2 from the father. Child 2 has inherited haplotype 1 from the mother and haplotype 2 from the father. Child 3 has inherited the father's first haplotype and the mother's first haplotype, and child 4 has inherited the father's first haplotype and the mother's second haplotype. So this will depend from case to case, but just to explain to you more or less how the haplotypes are inherited from the mother and father. So due to the inheritance of 2 haplotypes, we can expect 2 alleles for each locus. These alleles can either be heterozygous, in other words, 2 different inherited alleles per locus. And the example that I've given there is an A star 0101 from one of the parents and an A star 0301 from the other parent. These alleles can also be homozygous. In other words, the same allele that has been inherited from each parent. So this individual could have inherited the A star 0101 allele from the father and from the mother. The only exception to this rule is the DRB3, 4, and 5 loci, that are not classified either homozygous or heterozygous, but are rather classified as hemizygous. So depending on the DRB1 results of an individual, the following DRB3, 4, and 5 results may be applicable. So an individual can either have 2 alleles, so let's say, for instance, a DRB3 0101 and a DRB5 0202. Or alternatively, they can only have 1 allele, for example, DRB4 0101. And in certain situations, the patient may have no DRB3, 4, or 5 alleles. In the case of a patient's DRB1 typing results being either DRB1, DRB8, and DRB10, then you would not expect a DRB3, 4, and 5 result. So depending on the test methodology, HLA results can be identified differently. So the first example that I have there is an A23 split of A9. That is a serology result from many, many years ago. I doubt any laboratories still use technology for serology. The next resolution is a low resolution result, which would interpret the A23 as A star 23. And of course, the A star 2317 is an example of a high resolution HLA result. So if you look at the high resolution result over here, you've got a lot more detail for the patient that can be used for transplantation. So at SANBIS, HLA typing is performed using next generation sequencing technology. The workflow starts with a normal DNA extraction, and then we move over to the amplification step, the sample barcoding step, the library amplification step, and thereafter the library is loaded onto the Illumina MySeq instrument, which analyzes the results, and the data is then interpreted via the software of the kit. I must just specify that a high resolution HLA typing is currently a 3-day workflow. Cadaver donor testing is performed using a real-time PCR method and results in a low resolution result. The workflow for a cadaver donor test, considering all the tests that need to be provided for decision making for transplant, takes approximately 8 to 12 hours. So SANBIS is ISO 15189 accredited and also accredited to the standards of the European Federation for Immunogenetics. And being accredited to EFI, certain standards need to be adhered to. So, for instance, ambiguous results. Certain results cannot be resolved, and in that case, we need to report all of the alternatives for the ambiguous results. Homozygous results may only be reported twice or in duplicate if the homozygosity has been proven by haplotype and family studies. If not, the allele may only be reported once. And then the following 3 subpoints really all mean the same thing, and that is that verification HLA typing for the recipient and donor must be confirmed using a second sample prior to transplantation, and this is of course done for the safety of the patient. So HLA, the indications for HLA typing, there are a number of indications, and that is transplantation, solid organ transplantation. And I'd like to just mention a note here. Although unlikely, due to the diverse population in South Africa, a well-matched HLA donor is preferable to limit donor-specific antibodies and the development of de novo donor-specific antibodies post-transplant. Another indication for HLA testing is bone marrow transplantation, the identification of disease association to facilitate HLA-matched platelet transfusions, to investigate blood transfusion reactions such as TRALI and post-transfusion purpura, and of course to investigate neonatal alloimmune thrombocytopenia along with HPA testing. Those people that know me know the term that I use for HLA antibodies, and that is that HLA antibodies are a minefield. HLA antibodies are proteins found in an individual's plasma and is developed in response to exposure of non-self HLA molecules. So basically, HLA antibodies are not naturally occurring and are developed in response to sensitizing events such as previous pregnancies, blood transfusions, and previous transplants. HLA antibodies play a key role in the immune system, and important to note that HLA antibodies, once developed, don't disappear. Over time, the titers of these antibodies may drop, but upon re-encountering a previously exposed HLA, the memory response will quickly mount a much stronger immune response. This is just an explanation of how HLA antibodies are detected using Luminex XMAC technology and a micro bead platform. So the HLA antibodies are incubated with the beads that are coated with the specificities. A secondary antibody is then added, and then the sample is loaded onto a FlexMap 3D Luminex instrument that has two lasers. The one laser will look for bound antibodies that the secondary antibody has flagged, and the second laser will identify the bead, indicating what specificity is positive. So antibodies, HLA antibodies, can cause major complications. So to transplant, it can cause rejections and transplant failures. Patients can become refractory to platelet transfusions, and HLA antibodies in donated plasma can cause transfusion reactions such as Trali, and of course, well, PTP is an HPA antibody. There is a strong HLA antibody association in HPA negative antibody cases related to fetal and neonatal alloimmune thrombocytopenia. So the identification of HLA antibodies can be quite difficult for a number of reasons. There may be autoantibodies. A patient may have complement versus non-complement fixing antibodies. There may be antibodies to denatured antigens. There may be non-HLA antibodies present, for instance, MIC-A and AT1R. The antibody strength is something important. A female patient may have had a pregnancy event 40 years ago, and her current MFI antibodies might be quite low, but considering that the sensitizing event was 40 years ago, this certainly needs to be taken into consideration. And then, of course, patient medication also sometimes affects HLA antibodies. So if possible, it really is important to prevent sensitization of patients by providing blood samples that, blood products that are filtered, and also to ensure a high degree of histocompatibility between the patient and the donor to prevent the production of de novo antibodies post-transplant. And the sensitization history of a patient is very critical for HLA laboratories to assess HLA antibody results. How do we determine compatibility? Firstly, by ABO testing, we perform T and B cell CDC cross-matching. We can also perform flow cytometry cross-matching, which is more sensitive than the CDC cross-match testing. By determining the patient and donor's HLA typing, by assessing the patient's HLA antibody results, and also confirming all of this using virtual HLA class 1 and 2 cross-match results. We've discussed HLA in some detail, but let's quickly discuss what the importance of HLA is in blood transfusion. So certain patients require blood transfusions regularly. For instance, renal patients who undergo dialysis and leukemia patients that require platelets during the management of their disease. So in renal patients, or if renal patients don't receive leukodepleted blood products, they certainly can be sensitized to develop HLA antibodies, which may lead to the difficulty in finding compatible donors for transplantation. Leukemia patients who often receive blood transfusion, pooled platelet transfusions may sensitize these patients to develop HLA antibodies, which in turn leads to the refractoriness of platelet transfusions. HLA matched platelets may be required in these circumstances, and it's important to inform you that HLA matched platelets is often quite difficult to find and may be time consuming due to the lack of compatible platelet donors and the availability of platelet donors. I do just want to at this point mention that Sanbus has started producing pooled platelets that currently are filtered, but they need to be specifically requested. So definitely for leukemia patients that require platelets, I would advise requesting filtered pooled platelets for these patients. So HLA and HPA in blood transfusion is also important in the setting of transfusion reactions. Various transfusion reactions may be caused due to the presence of HLA antibodies. TRALI is not seen often, is rare, but is a severe transfusion reaction caused by HNA and HLA antibodies in donated blood, which is often found from females who have had multiple pregnancies. Post-transfusion purpura, transfusion reactions, may be caused when the patient has HPA antibodies and the donor platelet product has the corresponding platelet antigen. I'd like to share a case study with you. This is the case study of a 17-year-old female recipient requiring a renal transplant. The sensitization history of this patient is that she has had blood transfusions, and the patient's mother has been worked up for the patient. At the bottom here, you can see the HLA typing of the recipient and of the donor, although the entire HLA typing is not available in this specific case. The highlighted bold antigens are the haplotype that the patient and the mother share. And it's important to note that there are some unmatched antigens from the HLA typing. So the first time we tested this patient was in May 2022. And before I explain the results to you, I'd just like to give you some information about the picture that you're looking at. The graph on the side here indicates the mean fluorescent intensity of any antibodies that are identified. And these markers at the bottom are all the beads, the single antigen beads, that are coated with specific markers to identify the antibodies. So the highest antibody over here is a 1512 antibody with an MFI of only 150. This is very, very low and indicating really that there are no antibodies present at this stage for HLA class 1. This is the same recipient that was tested in May 2022, but now looking at the HLA class 2 antibodies. So there is one antibody over here, and that's the DQ beta 0501 antibody. That is a little bit higher. We're looking at about a 2,200 MFI for this antibody, which is significant, and we would report this antibody. So then this happened. In April 2022, 3 months after the initial testing, the picture of single antigen 1 or HLA class 1 antibodies look completely different. Previously, we had the highest MFI was about 150, and now we're looking at multi-specific high MFI antibodies of about 23,000. So there are major high antibodies that have now suddenly developed. If we look at HLA class 2, the same is applicable. We've got very high MFI antibodies, mainly to the DRB1 and DP alpha and DP beta loci. So what's going on here? Why did we see almost no antibodies pre-transplant and such a very big difference post-transplant? And why the dramatic change in results? So we did some investigation. And from a laboratory point of view, we established that the patient was transplanted in May 2022 after the initial HLA antibody testing. And from a laboratory point of view, there really are some important things to note. And what is that? We always need to investigate discrepant results. The first set of results were almost completely negative, and now 3 months later, we're seeing a complete picture. We need to think about things like, are we testing the right sample? Did we receive the correct sample? We may want to do some retesting to ensure that we are testing the right patient. And of course, the other thing is to know what the sensitization history of the recipient is. This is extremely important because this is now why we know there is such a big change, is the patient was transplanted. So let me give you some take-home messages. So HLA antibody, or not antibody, HLA antigen and antibody testing is critical to facilitate the treatment of various diseases. SANBIS uses state-of-the-art technology and instrumentation to provide the best results to treat patients successfully. It's very important for the doctor or the transplant coordinator or the nurse to provide accurate information of patient sensitization history, because this information is crucial when HLA laboratories assess antibody results. Where possible, limit the sensitization history of a patient by requesting filtered blood products to limit the sensitizing events. As per EFI standards, verification HLA typing must be performed on a second sample prior to transplant. And very important, when a patient has undergone a sensitizing event, for example, a blood transfusion, please resend blood samples to the laboratory 14 days later so that the patient's potential changed immune system can be identified. I just do want to show you what the tissue immunology request form looks like. This is what it looks like and is available on request. We are able to do ABO groupings, cross matches, cadaver donor testing, HLA NGS testing. We facilitate the HLA matched platelets. We can perform human platelet antibody screens and the corresponding platelet antigen genotyping. And of course, most important in my opinion, is the antibody testing, which also does need to be monitored post-transplant. And that's the end of my presentation, and I'm happy to just take any questions.
Thank you very much, Derek, for that overview. And as you can see, we will be giving you some time back this afternoon. But I hope this has refreshed your memories. I hope that we have some questions for discussion. And I really want to start off really what I thought would come up, and I want to thank Tomek for already answering this. And this is the fact that SanBis does have filtered pooled platelets available. I'm very happy to share an information leaflet with you. But basically, as Tomek said, this is a very good alternative in the absence of apheresis platelets, with the risk of sensitization being probably similar to that of a single donor unit. So in this filtered process, basically we're removing HLA, we're removing potential pathogens, less inflammatory mediators, and we are definitely advocating this product. So if you want that information leaflet, I can send it through to Nicole or the organizers. So I hope that has answered that questions. Please, if you can lift your hand so that Derek can respond to your questions. Let me see if I can also see them from where I'm sitting. So I see we've got 191 participants now, so thank you for that participation again. Are there any questions?
Dr. Uta, the one
Yes.
question that I can see is, what is the most efficient way of removing HLA antibodies? I cannot really speak to rituximab, although that is a immunosuppressive, if I am correct. But, you know, if a patient has HLA antibodies pre-transplant, and this patient does urgently require a transplant, then plasmapheresis can be performed to reduce the antibody load. Um, of course, cross matches need to be done to ensure that the antibody load has been reduced, and when it gets to an acceptable level via either antibody testing, we've determined that, and cross matching, then the patient can be transplanted. But it is a dangerous situation when a patient already has preformed HLA antibodies.
Thank you for that answer, Derek. So just for the audience, you probably know that SanBis does offer plasmapheresis services as well. And I guess the other thing that I would like to reinforce is what Derek also said, is that these antibody levels fluctuate, and for that reason, you intermittently test your patients, and even an antibody at a low level could resurge or potentially be a clinically significant antibody. Okay.
Sure.
So let me just see. We have a question here from Sipiwe Baloyi. There has been some concern that the antibody panel is not exhaustive. Do you have any information leaflet with the panel used?
So the panel that we use identifies and covers all of the most common HLA markers. There is a separate panel available, which is called an XFlex panel, that identifies additional specificities. so if I can give you an example, we can identify antibodies to A star 0201, A star 0205, and A star 0206, which really are the most common. But using the Xplex panel, we can identify further specificities, like, for instance, an A0211. It's not often required, but we can do it if required.
Yeah, and just to add to that, obviously this field is evolving all the time, and as these assays go through version changes, obviously the HLA community, lab community in the world tries to add new variants that are found to, to these panels, give the information to the manufacturers. And obviously in South Africa, we have a genetically diverse population. So for us, this is an even more relevant question. And when we find interesting variants, we do pass them on. But this is an important question. Thank you.
Yes,
I
great.
hope we've answered that.
No, thank you so much for the answer. It covers a lot. I think my issue is that on the reporting that I've seen, I'm not seeing a clear explanation of what exactly is being tested and not being tested. And so when I'm looking at a patient's report and typing, I need to know that you have specifically tested for antibodies to what my patient has, essentially. And I'm not sure then, like, how do I know to request additional testing if I don't know what's on the panel?
Yes. Look, I certainly can share the panel with you that is available. But if the donor does have a specificity, and we add this as a comment on the report, if the donor has a specificity to which we cannot identify an antibody, we do report it. So if there is not a comment, then all of the specificities of the donor is covered in the antibody test.
Do you send your testing to us?
I personally do not send testing to SANBIS. However, we do receive referrals from all over the country. And so we do often encounter the reports.
Okay.
I think my main thing would be I would like to have a comment on that in every report to say all the specificities have been tested in this patient, or we weren't able to test this, instead of having to sort of muddle, did somebody miss it? Did they forget?
So,
yeah.
Dr. Manoy, if you don't send work to us, just go and speak to the referral laboratory that does perform your testing, and just inquire with them, because it is important to make sure that the specificities of the donor are covered by the antibody panel. And that laboratory should really put a comment on the report. So, maybe just go and speak to the laboratory that is performing your testing. And if you want, I can certainly share with you our panel, but not every laboratory uses the same kit. Certain laboratories may use a different supplier's kit to us. And so just speak to that laboratory.
Andrew, I saw you had your hand up.
Yeah, so a couple of comments. One, let's first just to this question at hand in terms of the panel specificities. I mean, CP, we actually, well, Derek, a lot of the labs actually in South Africa are using the same kit. I got the list from all of you last year, and essentially, I agree that when we're sending for DSAs, we should actually be sending. So if you haven't done the tissue typing, we should be supplying with the tissue typing. So that is a defect. But CP, what I've also been doing is when we've got mismatches, I'm actually physically going through that list and see if that antibody specificity is on the DLI, the HLA antibody panel. So, and we've actually come across quite a few where we've actually missed. So, kind of just practically, what I've kind of been doing is that if the patient has lots of other antibodies, then you can provisionally treat them as potentially positive. But if they've got very few HLA antibodies, then I'm not too concerned in terms of going forward with a transplant. But I'm actually physically checking against the panel. So the panel's readily available, and Derek can share it to you. I mean, unless it's changed from last year, I can also share it to see if we. I mean, I think that's a very useful thing to have the panel specificities. But I mean, these things are drawn up by European/American manufacturers, where obviously, you know, the HLA genetics, I mean, the typings are slightly different, and haplotypes frequencies are different. So I think that is really a big issue that we need to take cognizance of, that we're not missing HLA antibodies. So that was just the first comment about the test itself. Interestingly, we've also seen one auto HLA antibody, Derek. Really kind of makes your hair turn when you see a HLA antibody against a patient's own specific I think it was a DP, I think. So I have seen that as well. And then just in terms of comment about complementing SANBIS, I mean, about 10 years ago, we were still getting predominantly pooled platelets. That situation has changed, where over 90% of our platelet supply now is actually single donor apheresis. So really kudos to you to turning that ship around. And then just to Sharok's comment, I mean, if they're really high MFIs and we really want to use that donor, then I know Donald Gordon and us are, I'm not sure what the Cape Town units are doing, but are following so the MD Anderson plan, which is essentially everything, a kitchen sink and everything else. So bortezomib, plasma exchange, IVIG, and also a shot of steroids as well. So really are showing, and as well as rituximab, sorry, addition of rituximab. I mean, there's also buffer coat depletion of antibodies, but that's a bit more difficult to do. So you actually expose the plasma to patient antibodies. So it's actually but that's, I know Justin's always been, I'm not sure if Justin's back. Has always wanted to do that, but I don't think any of us are actually proceeding with that. So just, yeah, that's the plan for sort of high risk patients.
Yeah, that's true.
Thank you for that input. That's always useful. From a lab, what we are also planning, just, you know, now that we FE accredited, and you get better information what other labs are doing and better recommendations. What we want to look at in the near future is pre-treating our samples with EDTA. Derek, I don't know if you want to tell our audience a little bit about that, what it does to your results potentially. Oh, it's actually been validated in other labs.
Sure. So EDTA assists with a whole complement problem. And EDTA actually treats or removes the prozone effect that can occur in highly sensitized patients who have HLA antibodies. So what it really means is that you may see a patient with several antibodies with an MFI of, let's say, 6,000 to 8,000. But when you then treat that patient with EDTA, then the MFI shoots up to 20,000. Historically, SANBIS has not been doing this, but after a recent EFI audit, we've been strongly recommended to do that. And so a validation will be undertaken very shortly to validate the effect of EDTA on highly sensitized patients to prevent the prozone effect.
Thank you. We see there's one more. Oh, you could also try DTT. That's quite correct.
Correct. Thanks,
Yeah.
James.
Thank you.
We currently actually use DTT, James, just to clarify, but you know, the EFI auditors, as well as a lot of online research that I've done, actually stipulates that EDTA works better than DTT, funny enough. Dr. Uta, I see that Deborah
Yes.
Vaz has her hand up.
Okay, Deborah, please speak up.
Hi, hi, Derek.
Yes,
Thank you for the
hi.
talk. It was really, really good, and it's definitely something that I'm interested in. So I have a question regarding the haplotype. So when you do typing on a patient, it gives you the results for the patient. It gives you an A, B location, C location. So it gives you 2 locations for each. But
That's
how
correct.
do you know that that combination, you know, makes a haplotype? Unless you have the family studies. Is that right?
Correct. Correct.
Yeah.
You know, there are 2 ways of doing it. You know, between a patient, or shall I say, in a family with a mother and a father, there is the possibility of 4 different haplotypes. So you either need to test the parents of the patient, or all 4 haplotypes need to be demonstrated between the patient and donor or donors. And if
Yeah.
that is then not demonstrated in the testing, you cannot be sure about the haplotypes. The only way really is to test the parents. And I know it adds cost to testing because you have to test additional people, but really it is the best way to do it.
Yeah.
That is
Because
really the best way to do it, is to test both parents.
I mean, because there's studies that are doing, you know, the population studies of HLA, and they do a lot of haplotype frequencies and matching probabilities. And I was curious how they work out those haplotypes, you understand, from just a database of HLA types. Because how do they know that that combination forms a haplotype, if you know what I'm
That
saying? So I was just curious what your thoughts were.
Yes, no, and you're correct. You know, a haplotype does need to be confirmed, and it normally is confirmed using the parents' HLA typings, and I don't know how haplostats there are. Links and websites available. I would assume that the people who have contributed stats would be sure about the haplotypes before adding it onto a database like that. The way
Yeah.
we would do it is definitely by testing the parents, or by the demonstration of all 4 haplotypes between a patient and siblings.
Yeah. Yeah, that makes sense. Okay. No,
Sure.
well, thank you. I
No,
appreciate your input.
it's my pleasure.
Are there any more? I don't think there are any more hands. Yeah, I think this was succinct, a good revision. I thank you for all your relevant questions. I think we're all going home with something, and I'm sure you're happy that we can end this meeting early. So if there are no more comments, I would just like to thank Derek, and also tell you he doesn't only do HLA, he also likes camping. It's one thing I forgot to say, so that's where he
No
gets
problem.
rejuvenated. So Derek, thank you very much for coming to this big audience. I know it was a bit last minute, so thanks for daring that and doing a good job. Thank you. Thank you, everybody. Have a
My
good
pleasure.
afternoon.
All right. Bye-bye, everyone.
Don't forget the link to the attendance register. It's also in the chats. Derek, don't forget, it's there.